Oops. Hello, good morning. This is me, Dr. Zubia Kahn. I am an international medical graduate from India, and today I'm going to speak about neuromyelitis optica spectrum disorder, also known as NMO. Let's talk about this. So I'm going to cover up these topics, starting with the introduction. It is also called as Devick's disease, since it was first recognized by Dr. Devick in 1894. Regarding history of NMO, it was first regarded as a variant of multiple sclerosis, but later on, with the discovery of antibodies to aquaporin 4 channels, it was considered completely different entity. So now let's understand what is NMO. So it is an autoimmune disorder that affects brain, eyes, and spinal cord, leading to severe demyelination and inflammation. And just to make it simple for my non-medico friends, most of the patients present with recurrent transverse myelitis, that is inflammation of the spinal cord. Also, they may present with optic neuritis, that is inflammation of the optic nerve, and there should never be a multiple sclerosis. So let's talk about it in detail. Transverse myelitis, because the patients presenting with transverse myelitis, mainly their MRI depicts more than 3 vertebral segments lesions. Mostly they are long white lesions, and they present with the high amount of pleocytosis, and there is a high rate of recurrence. And patients presenting with optic neuritis, they can present with unilateral or as well as bilateral, and even sometimes recurrent optic neuritis. But as I said, it should never be multiple sclerosis, because if we go and look in the MRI of the NMO patient, there is no as such symptomatic lesions present. Plus, there is a strong seropositivity of NMO IgG, and there is no oligoclonal bands as which are seen mostly in MS. Now, since it is a spectrum of disorder, most of the symptoms are of MS, and most of the symptoms are also of transverse myelitis. And it is a combination of both, and it has overlapping features of both. Talking about epidemiology, it has widespread distribution in the whole world, mostly in the developed countries. The percentage is quite low, and mostly it is seen in underdeveloped and developing countries. And coming to the United States percentage, so there is a high percentage in both Caucasian as well as the Black community. It can present at any age, but the mean age of presentation is around 40 years. There, it can be seen even in pediatric population as well as geriatric population. And there is a 6.5 ratio and high predominance of female to male ratio. Looking at the pathogenesis, so when this NMO IgG antibody, when it binds with complement, it leads to inflammation. So this is how a normal optic nerve looks like, with myelin over it. And after the antibody destroys it, it looks like this. So the main pathogenesis behind this NMO is the demyelination and inflammation, mainly involving the astrocytes and leading to axonal loss, peripheral these perivascular lymphocytic infiltration. And unlike multiple sclerosis, it has more severe necrotic and cavitary lesions in the cord, and it involves both gray and white matter here. So there is not much information regarding NMO in the books because it has been recently been recognized. And regarding signs and symptoms, most of the patients present with recurrent transverse myelitis. And other than that, they can simply just present with only optic neuritis or sometimes both, and sometimes even neither. So I saw a patient in our clinic. She was having negative NMO antibodies, but she did had weakness on her arm, one-sided, unilateral, and she was also complaining of urinary incontinence. Now, coming to the acute attacks, during acute attacks, patients may present with uh, neurological worsening, which can reflect focal and multifocal CNS lesions, and their symptoms can last from 1 day to even more than 30 days. So these are the common symptoms that they can present: weakness, numbness, tingling, visual disturbance, and even color blindness. And urinary incontinence. Pain is the main symptom of presentation. And most patients present with depression, cognition, and fatigue, and even severe vomiting and hiccups. So it could be a result of a new lesion or a relapse, or it could be presentation of a past damage that is now showing its symptoms. So there are two types of pain presentation. Either it could be a neuropathic pain, or it could be pain due to the contraction and spasm of the muscles. These are the common similarities in NMO and MS. Both of them cause demyelination, but the difference in NMO is it affects only optic nerve and spinal cord, whereas MS, it is disseminated in space and time, can have variable presentation. These are the comparison between NMO and MS. So going down there, NMO is mostly about humoral immunity, whereas MS is about cell-mediated immunity. On the MRI, you may find white matter lesions in MS, and it's a typical MS pattern. Whereas in NMO, not much lesions can be seen, but long white lesions can be seen. It causes permanent CNS destruction. Whereas in MS, it's a remitting, relapsing disease, and patients can quickly recover it. MS patients have oligoclonal bands, and whereas for NMO, they can have seropositivity. Now, as we can see this graph, you can see NMO is on top. There is a high recurrence rate, as well as there is high rate of humoral autoimmunity. Now, how to diagnose NMO? So there is an antibody named anti-NMO or anti-aquaporin 4 antibody. These are antibodies present against the water channel aquaporins in the astrocytes of optic nerve and spinal cord. And it is only this antibody that causes all the demyelination and axonal destruction. So there is very high specificity of this test. Mostly 80% of the patients are detected positive with this antibody who can present with optic neuritis, or who can even present with transverse myelitis, or sometimes even brainstem lesions. And even if it is negative, then and if you think there is high suspicion of NMO, then the repeat testing can be done in 6 months. And it could be a diagnosis of exclusion if there are more than 2 lesions present on the MRI at more than 2 locations. So there is also a chance of false negativity if some patients are on immunosuppression. Now coming to the MRI, the typical MRI of an NMO patient may have 46% chances of spots, and some may be normal, and some might present with similar lesions like MS, but they tend to be very short and small. So here you can see MRI spine. There is a long white lesion, if you can see. And in another view, you can here also see there is a lesion, and after contrast, there is a small lesion here, which shows inflammation. And these are different eye tests that can be used by the ophthalmologist. We can do visual evoked potential test. We can do a visual field test to see any central or peripheral defects. And we can do OCT to measure the thickness of the nerve fiber in the optic nerve. Now, coming to the treatment, the main rationale behind the treatment of NMO is based upon the humoral immunity. And so like any other autoimmune disease, the earlier the treatment, the better it is. And in acute therapy, the management of acute presentation, mostly it is done with steroids, IV steroids. And if that doesn't work, then plasma exchange or plasmapheresis can be considered. There is an ongoing pilot safety study going on oblituximab. It's a monoclonal antibody against CD20, and it is mostly for acute relapses of NMOSD. For prevention, these immunosuppressant drugs can be considered rituxan. Most of the physicians use rituxan, then azathioprine, mycophenolate, methotrexate, tocilizumab. These also can be considered. But recently, since 2019, there has been a number of drugs, newer drugs for the patients of NMO positive antibodies. So first is Solaris. It is a monoclonal antibody that blocks complements. Next is Uplizna. It depletes the CD19 B cells. And the last one is Enspryng that blocks interleukin 6. Now regarding prognosis, here we can see there is a high percentage of relapse in the patients with optic neuritis, and late in the younger age, and later after 50 years, there is more percentage of relapses in the patients presenting with transverse myelitis. So as we know, there is a high chance of relapse in NMO, and there can be worsening of NMO symptoms. They can present with fever, infection, or there can be worsening with increased temperature, exercise, stress, and even with medication changes. So a few months ago, while searching about this disease online, I met a girl named Sumaira Ahmed. She was crowned as Miss Bangladesh USA in 2015, and she herself was diagnosed with NMO. So her disease motivated her to lay the foundation of TSF, the Sumaira Foundation, and it is a non-profit organization that creates global awareness to raise funds for research and development to find a cure for NMO. And it gives a sense of purpose to the NMO patients and to let them know that they are not alone in this fight against NMO. So March is the NMO awareness month, and so they take care of all the pains that the NMO patients go, and it's a small community, and it's creating awareness. With this, I want to let you know that these are the references I used to prepare my presentation. And in the end, I would like to thank Dr. Burnett and Dr. Stein for giving me this opportunity. I would also like to thank my mentor, Dr. Ali, and my parents and my fellow colleagues and friends. Thank you.
Thank you.